Palliative care can come into play at any time in a person's life, from the day they're born to the day they die. It's essential to understand that palliative care is all about treating the person. And we know that when patients or people are diagnosed with potentially life-threatening disease or serious illness, that is a very scary process, and there begins the suffering. They may not have physical pain, but they may have emotional, existential, or spiritual pain. And that sort of distress should be adequately treated at any stage. So age is not important. It's a service that's available at any time or any stage of one's life. Absolutely. For the very same reason, you're able to be more preemptive, if you will, more preventative of potential complications that could be physical or involve the other domains that I just discussed. And the sooner that you're able to get a better sense of what the patient wants for themselves, understand their values, understand what matters to them and their families, the better you are to get them to play a part in the treatment plan and to really help you come up with a specific treatment plan that works for them and their family. And there is where some of the savings and potential benefits occur, not only locally within that patient and family, but within the system as well. I think a huge emphasis, and you know, palliative care is always done in collaboration with all of the other physicians that are involved or teams that are involved in the patient's care. And so with better integration and collaboration as far as the information that you're providing to the family regarding prognosis, regarding treatment measures, regarding outcomes, you get a better sense of what works for them based on whatever the medical limitations are. In some cases, there are situations that we can control, and in some cases there are not. But as long as the family and the patient are a part of the treatment plan, and the team is sending the same message, you get better outcomes, you get better utilization of resources, you get better satisfaction. I think that depends on where you are. Here at Hackensack, we have the John Thoreau Cancer Center where we work hand in hand with the oncologists. Typically, since I've been involved in palliative care, oncologists specifically have been considered to be more difficult fruit to get at, not the low-laying fruit. But that's changed, and as we get younger oncologists into the field who have some background in palliative care, who have some understanding, I see that that's really changing. And with the educational efforts and the collaboration that we've provided here, also in the more seasoned oncologists, we've seen that they've really begun to appreciate what we do. I think one of the reasons traditionally that there might have been, if you will, some resistance to palliative care is just misunderstanding as to what palliative care represents. And obviously I'm referring to either an end-of-life care scenario or hospice, which is one of the questions you asked for at the very beginning. When is palliative care appropriate? It's appropriate at any time. It seems as though, and especially from the lay public perspective, that people more liken it to end-of-life and hospice, and it has to be clearly understood that that's absolutely not the case. We do it by education, we do it by promotion, we do it by, you know, individual to individual, case by case, the different physicians that we work with. Sometimes it's one family, one patient at a time. And it turns out, because there are so few trained clinicians in palliative care, that there is a whole population of advanced practice nurses that can become palliative care certified. And I think their presence is essential, and as a matter of fact, there are a lot of programs in this country that are run by nurses, not run by physicians for whatever reason, but most of the times it's just because the resources are expensive. So their benefit is essential. Our own experience within this institution in attaining advanced certification, et cetera, could not have been done without nurses at the front line and advanced care nurses and their participation. There is, and there are a lot of advanced practice nurse training programs around the country that have sprouted, which is an excellent thing, but really the demand is great on both ends, physician and nursing, and there's not nearly enough trained clinicians across the board in the country. There's a huge deficit, and along with that comes the importance of changing the curriculums in medical school, the importance of putting much more emphasis on research and recovering monies, government money, government funding to put programs together, because there's a big deficit. You know, I see within the state of New Jersey, which I have more specific information, that they actually have put together little nursing consortiums and steering committees so that the advanced practice nurses within all of the different healthcare institutions in this state are communicating with each other, experiences, programs, different services that have worked effectively, plans that have not worked effectively. I've seen great benefit from that. There's a whole branch of the Academy of Hospice and Palliative Medicine that is nurse-driven, which is the nurse's version. That is a huge resource. I think collaboration and discussion among nurses, as I mentioned, is a very big thing. And in this field, being relatively young, there's a lot of spirit of camaraderie, cooperation and collaboration. And I see it as being very successful. Our nurses come to the table all the time with feedback they're getting from their nursing groups.